Awesome. Thank you so much for that introduction, and thank you all for taking time out of your week to come attend this presentation. Before I get started, this presentation is going to really be broken down into two different disease processes. First is erectile dysfunction, and the second is stress urinary incontinence. For more information about erectile dysfunction, I highly encourage you all to either visit that link or use that QR code. A lot of what I talk about tonight will be reiterated there, as well as some patient-facing data. Just a little bit about me. I go by my middle name, so that's hence the Jake Fantus. My first name is actually Richard. I'm a Midwesterner through and through. I did undergrad at WashU. I did briefly deviate to go to Baylor for medical school, but then did the remainder of my training at the University of Chicago and Northwestern, where I did a fellowship in infertility, andrology, and sexual medicine, which includes prosthetic urology. And then I originally was in practice up in Chicago before moving here several years ago. So let's talk a little bit about erectile dysfunction. As you can see, the definition is somewhat subjective. It is really incumbent upon you as the patient to tell us that you're having a problem achieving and maintaining an erection that's firm enough to perform sexual intercourse. That means that sometimes it may be firm enough, sometimes it may not. That's considered dysfunction. It should be as firm as you want it when you want it. It's an incredibly prevalent disease process, and it affects almost 1 in 5 men aged 20 and older. Recent epidemiologic surveys suggest that it affects up to 50 million men in the United States, and that half of men by the age of 40 will have some symptoms. Again, that's subjective definition, but some symptom of erectile dysfunction. Briefly, erections are a multifaceted process that requires a whole host of intact different types of tissues. It involves your nerves generating a signal telling your arteries to open, allowing blood into the penis. And then it requires that enough blood gets in the penis to dilate the soft tissues. As these soft tissues dilate, they then pinch off the exit or the veins and achieve an optimal pressure for a rigid erection. This slide is very short compared to the number of causes we really know are associated with erectile dysfunction, but suffice it to say, these are some of the most common. And what we know is that a lot of these different disease processes affect those different types of anatomical structures I just discussed. Aging most commonly hardens the arteries and can desensitize some of those nerves. Smoking, again, causes artery-based damage. Diabetes damages the arteries, the nerves, and the soft tissues as well. High blood pressure, problems with cholesterol, again, can primarily damage the arteries. Depression is an interesting one. It obviously can involve different hormone levels as well as neurochemicals that involve erections, and then obesity, which obviously has long reaching impacts that kind of involve both the diabetes side as well as the vascular side of things. And this point at the bottom of the slide may be more important than everything else I just mentioned, that erectile dysfunction is important really beyond erections. It has a lot of psychological effects as well, not only for the person experiencing erectile dysfunction, but also for the couple. I can't tell you the number of patients who will come in and say, this is affecting my relationship. My partner feels as though I'm not able to perform, which in turn causes the patient to feel even worse about their inability to perform, feeling like they're to blame for some pathology that they have. We'll go into some of the specifics about the links. I did briefly discuss the relationship between how diabetes can affect erectile dysfunction. But what we know is that as diabetes becomes more and more prevalent, so is the relationship between diabetes and erectile dysfunction. If we look at any of the specific pathologies that overlap, diabetes is one of the top contributors to ED. It's also known that men with diabetes, especially if they ever have a history of poorly controlled diabetes, are notoriously poor responders to a lot of our first line medical therapies. Again, talked about this briefly, but erectile dysfunction from diabetes occurs at multiple steps. It occurs both in the blood vessels and in the nerves. And that's why sometimes the pills do not work as well. It's because the structures are damaged to the point where perpetuating an erection signal doesn't work because there's inadequate chemicals to kind of start that cascade off to begin with. So, what things may increase erectile dysfunction in men with diabetes? So, what compounds your risk of developing erectile dysfunction? Well, again, things that would put you at independently at risk for erectile dysfunction. Being older, which can cause, again, arterial hardening, the length of time that you've had diabetes, where you're a type 1 diabetic or a type 2 diabetic and have only had it for several years. And again, glycemic control or the ability to keep your blood sugars in the normal range. The longer you've had poor blood sugars, the more likely diabetes is going to damage both your blood vessels and your nerves, which can lead to erectile dysfunction. Different treatments for diabetes can also cause issues. The diuretic treatment mentioned here is an overlap with people who have diabetes as well as high blood pressure, but some of those are notorious for causing erectile dysfunction beyond just that of the disease process. And again, men with diabetes are also at higher risk for heart disease, and heart disease is an independent risk factor for erectile dysfunction. If you take nothing else away from any part of this presentation, please take away information from this slide. Erectile dysfunction has been shown to be the metaphorical canary in the coal mine for men with coronary artery disease and heart disease. It's been shown that men, especially young men, that present with erectile dysfunction are at much higher risk of manifesting heart attack or heart attack-like symptoms within several years of diagnosis. In fact, there's some data from the Mayo Clinic showing that men under the age of 40 presenting with erectile dysfunction were at significantly higher risk of having a heart attack compared to those who did not have erectile dysfunction. So for any of you out there that are suffering with erectile dysfunction, if you haven't seen your primary care physician in the last year, I would highly encourage you to go back to make sure there isn't something else that's contributing to this and your overall health. And again, just like diabetes, a lot of times the disease severity is directly related between the cardiovascular issues or the heart issues and the erectile dysfunction. I really like this slide because it kind of demonstrates the caliber or the size of the different arteries in our body. You can see the penile artery at 1 to 2 millimeters all the way on the left of the slide. And on the right, you see a large blood vessel, the femoral artery that's in the leg. And this is one of the reasons why we think that any disease in the penis can precede diseases in other main parts of your body. And that's because those arteries are so small, they're more susceptible to perturbations in flow or being clogged by things like plaque. I guess I lied. This may be the single most important slide, but this is, along the same vein. There are things you can do to not only reduce your risk of having a major cardiac event, but can also independently help your erectile function. The two most important things are number one would be losing weight, which should be ideally through diet and exercise. And the second thing would be if you are smoking, obviously try to cut back or quit smoking. Those are the two independent things you could do to increase your life expectancy as well as increase your ability to have an erection. It says here to take steps to reduce stress. I've always found that very challenging. There are definitely good ways to do so, but just telling somebody to be less stressed is usually a very challenging task. And then what I said earlier, please see your regular primary care physician or family physician if you haven't seen them, in the last year or in a while, or if you have new medical conditions, because a lot of these diseases, again, grow in parallel. We'll talk a little bit about some of the intersectionality between low testosterone and erectile dysfunction. As I said, part of my fellowship is in andrology, which is male hormone replacement. So I see lots of men for this as well. Low testosterone occurs when somebody has lower levels of the blood hormone testosterone. If you go to the AUA guidelines or the American Urological Association, simply having low levels of testosterone outside of some, outliers isn't necessarily dangerous. But what we do note is that men who have low levels and symptoms are people that are at risk for having problems like erectile dysfunction, decreased sex drive, problems with uncontrolled weight gain, problems with building muscle. This is a laundry list of different symptoms somebody may have. So it'd be very rare for somebody to come in, have a low testosterone, and not be complaining of one of the following: depression, difficulties with concentration, inability to lose weight, enlarged male breast tissue, again, energy, sex drive, erections. I mentioned the prevalence of all these other diseases, but again, it would be pretty rare for somebody to have low levels and not have a single symptom of testosterone deficiency. What we have here are some options for treating testosterone therapy. What I can tell you is that a lot of symptoms do get better. Not all the symptoms I just mentioned. This would be a completely different consultation than the ones for erectile dysfunction. It's rare that somebody's testosterone level by itself, except in select circumstances, that treating this would necessarily reverse somebody's erectile function. What we do know is that people taking testosterone or having a normal testosterone are more likely to succeed in a lot of the other options, which I'll talk about later tonight. So it's more of a adjunct to helping us get the maximum benefit of our other therapies rather than being a single therapy for erections by itself. We're going to digress briefly and talk a little bit about, again, the overlap between prostate cancer and erectile dysfunction. I think it's important to mention that prostate cancer is often relatively asymptomatic for most men. Erectile dysfunction is not a sign or symptom of prostate cancer. However, it can be a result of some of the things that we do to treat prostate cancer. One of the biggest things that we do is to remove the prostate and some of the surrounding tissue. And what we've learned through decades of experience is that some of the nerves that are responsible for erections, again, those nerves I mentioned that send that signal to the arteries to dilate and begin that entire cascade, actually course very close to the prostate. Therefore, in doing the procedure, if those nerves are injured, it may cause some challenges in men getting erections after prostate surgery. Now, with modern techniques, injuries are less common than they were decades ago. And some of these injuries are not injuries that are permanent, meaning the nerves aren't cut, but are simply stretched in a way that they may take several months or even years to recover. This is a brief depiction of what prostate cancer surgery looks like. You can see the prostate on the left. On the middle, you can see that we have removed the prostate. And then on the right, you can see that we've reconnected the system. As we start talking about stress urinary incontinence a little bit later, I'll kind of discuss why this is important. One thing this slide is not doing a good job of showing is it magically shows how the urethra, that area that is between the blue areas, is just put back to the bladder. And that's not completely true. We have to move these tissues to be able to do that, which can lead to some other problems. This again is surrounding mostly around the prostate cancer treatment with prostatectomy, and that men who undergo surgery for prostate cancer do have an increased risk of erectile dysfunction. If you look at the literature, that risk tends to be somewhere in the neighborhood of 50% of people developing some kind of new form of erectile dysfunction. And a lot of this is dependent on what somebody's erectile function is going into prostatectomy or prostate removal surgery. If you required medications to get an erection beforehand, it's unlikely that the surgery is going to reverse that. And if anything, you may have more advanced erectile dysfunction after the procedure. And again, even with the most advanced techniques, this says that your symptoms may persist beyond a year. What we know is that that's actually can be longer than that. We see men that recover erectile function sometimes 18 months to 2 years after. The problem with this is that there are two things happening. One, you are recovering from the procedure, but two, you're also aging. And as I mentioned, age is an independent risk factor for worsening erectile function. So as you see, as you recover, other things may come up that are independently also hurting your erectile function. It didn't mention it, but there are other forms of treatment for prostate cancer, such as radiation therapy. Those treatments and hormone deprivation have also been associated with problems with erections. Other things associated with erections that are sexual issues would include things like Peyronie's disease. Peyronie's disease You probably Google this online. Some of you have seen these pictures. There's a lot of direct to consumer marketing, and they talk about how trauma causes, people to have these plaques in their penis. Realistically speaking, we don't have a great explanation for what causes this. We think that an accumulation of trauma or micro trauma or just simply sexual events over the course of a lifetime, and people with some genetic predisposition who are more likely to develop these plaques do. Sometimes it's triggered by other inflammatory events, such as different surgeries. But what we do know is that men with Peyronie's are more likely to develop erectile dysfunction, and men with erectile dysfunction, similarly, are also more likely to develop Peyronie's disease. As I said, it's an acquired deformity of the penis. Again, the marketing to a lot of patients has traditionally been that there's a plaque that causes a deviation of the penis. But this deformity can, vary in both location, size. It can actually be a annular or circular narrowing at the penis. It could be parts of the penis that no longer get hard while other parts do. That can lead to things like penile instability, meaning, during insertion, the whole penis is weak and bends in certain areas. So there are a host of different deformities that can occur with Peyronie's disease. The silver lining is that Peyronie's disease is a benign process. One of my counseling talks usually is that this is nobody dies of a bent penis, but it can certainly cause a lot of different problems with sexual intimacy, and we have a lot of good solutions for that. Solutions range from oral medications, which are really designed at decreasing discomfort around the time of the shape changing event or the active phase of Peyronie's disease. And once it's stopped changing, our therapies change from pills to either injections into that area, that plaque itself, to help destabilize it, stretching activities, traction devices, which are devices that are designed to bend your penis into a normal configuration while it's flaccid to kind of stretch out the plaque itself. And there are a whole host of different surgical procedures used to either remove the plaque or to simply shorten other dimensions of the penis to help make the patient straighter. Another surgical option, especially for men who have both erectile dysfunction as well as Peyronie's disease, is simply penile implantation surgery, which we put a prosthetic device in to not only allow us to then manually straighten the penis to a straight configuration, but also head off any advancing erectile dysfunction that may require more advanced therapy later and take care of everything at one time. This is a little bit more of what I was just talking about. Sometimes it's best that we treat both things concurrently. This is really a fairly nuanced conversation, and it has a lot to do about patients' quality of life and desires, as well as how bad each one of these pathologies are. If the Peyronie's disease is something like a 30-degree bend and the patient's erections are strong, penile implantation surgery may not be the best option. If somebody's erections are bent at more than a 90-degree curvature and they're taking oral medications for erections, then the surgical reconstructive options may lead to worsening erectile function, requiring injections or ultimately requiring an implant. And that may be best to discuss doing an implant up front. But really, whether or not that's the right option, we'll discuss a lot about the nature of the disease processes and then the patient and the partner's sexual desires. All right, we're going to completely shift gears here. I know we spent a lot of time talking about erectile dysfunction, comorbid conditions that are associated with it, heart disease, diabetes. We talked about other urologic conditions that are associated with it in things like testosterone deficiency and Peyronie's disease. Before we get too much into the different types of treatment options for erectile dysfunction, we'll talk a little bit about something else that's incredibly important to men's health. And this, again, is also related to prostate surgery and prostate cancer, and that's stress urinary incontinence. Again, for most of the stuff that I'm going to say beyond now with regards to incontinence, this QR code will link you to a site that, again, corroborates all of what I'm saying, as well as having patients experience. So what is stress urinary incontinence? Well, incontinence is simply the leakage, the involuntary leakage of urine. But stress urinary incontinence is a specific type of incontinence where any stress put on the abdominal viscera, your abdominal cavity, causes the involuntary loss of urine. And that includes things like coughing, laughing, sneezing, physical activity, lifting weights, and that can all cause the involuntary loss of linkage. And that's more of a mechanical problem than somebody who says they have to go really bad and can't make it to the bathroom on time. It's a fairly prevalent condition. Doesn't affect nearly as many people as erectile dysfunction, but we do know almost 20,000 new people develop bothersome stress urinary incontinence a year. Let's talk about a little bit of the pathophysiology of that. We know the bladder stores urine, and then you get to follow that bladder on that pathway that looks the same color as the inside of the bladder, all the way down to the tip of the penis. That's the urethra. The two most important structures for continence in a male are number one, the prostate, and that's because of its interface with the bladder neck, as well as the sphincter muscle, which you can see also abuts the other side of the prostate. So we have two separate mechanisms for continence. When the body tries to urinate, the bladder contracts, allowing the flow of urine. The bladder neck opens, and the sphincter muscles relax to facilitate urine passing. You can imagine if that prostate was not there, or there was damage to that sphincter muscle right there, or a combination of the two, we'd be in a situation where there'd be little resistance offered, and that any pressure put on the abdomen or onto the bladder itself could result in the emptying of the bladder or the leakage of urine. By far and large, the most common cause of this is iatrogenic, meaning we did this. By we, I mean typically urologists. And it's associated with prostate removal surgery for prostate cancer. Occasionally, it can be associated with prostate removal surgery for benign causes, such as urinary retention or really bad benign prostatic hyperplasia or urinary symptoms due to the growth of the prostate in a non-cancerous way. Sometimes it's due to a combination of that and radiation therapy to the pelvis, but the vast majority of stress urinary incontinence is a result of prostate cancer treatment. This may be more true than the associations with erectile dysfunction, though that will be up in the air. I think both of these conditions that I'm talking about tonight, it cannot be understated how much they can affect a patient's psyche. Being wet all the time, having the fear that you're going to leak, even if you're not leaking, not knowing where the bathroom is, not knowing if you have enough pads or diapers to make it through wherever you're going, the odor that can be associated with this can take somebody who was once a fun-loving person and turn them into a recluse. They're afraid to go to the golf course. They're afraid to go to their, any social event. They're afraid to go to a movie because they feeling that they're going to leak anytime they cough or laugh during the movie. And there's a significant association between incontinence and depression for that reason. So this is more of what I was talking about. And we talked a little bit about the incidence, right, being 16,000, not quite 20,000 per year. And we perform quite a few prostatectomies a year. This number is fairly recent. This is a 2024 publication. And if you look towards the number of people that have bothersome leakage after prostate surgery, those numbers range somewhere between 5 and 16% of men. Back of the envelope calculation is, you can already tell this is where the vast majority of the cases come from, the smattering of other things. But this is really an issue. And this is a cancer survivorship issue, meaning that we can do a lot of great things to extend your life and prevent you from dying of prostate cancer. But we need to be better and make sure that we're also able to offer you treatments that once we extend your life, that it's meaningful and you don't leak urine or have the associations of depression with leaking urine or don't have erectile dysfunction. So this is a slide from earlier, and I told you we'd revisit it. This is us revisiting it right now. And if you look at the right, again, I think this is slightly misleading just because there is a repositioning that happens of the urethra in some men that leads to this incontinence because that urethra is not optimally aligned with the sphincter muscles. All right, again, I'd encourage you to visit that QR code I had before for the stress urinary incontinence. The remainder of the talk is going to be going over all the different treatment options we have available as of 2024 for both erectile dysfunction and stress urinary incontinence. So, first of all, who treats erectile dysfunction? what we know is the first place of most patients' contact does happen to be the patient's general practitioner, internist, family doctor. And there's a recent survey that even suggested that more patients wish that those first points of contact actually asked about this. I said this is a very prevalent condition, but sometimes it's incumbent upon the patient to ask the provider, hey, I'm having a problem down there. Can you help me with that? Whereas a lot of patients have shown that they will love to have the provider actually say, are you having a problem with this? So they can provide the appropriate referral. So again, just a brief aside, I would empower all of you, all of your friends to make sure if this is something bothering you, to bring this up with your internist so you can be seen by the right person. Typically, that right person will end up being a urologist at some point. Urologists are surgeons that are trained in the management of both men and women in general urinary diseases. Most board certified urologists are capable of doing some, but not potentially all of the treatment options for erectile dysfunction. But it's important because they can also deal with the complications that can occur with several of the different treatment options that I'll go over in a little bit. A prosthetic urologist is a specific type of urologist, typically fellowship trained in doing the surgical implantation of different devices that treat both erectile dysfunction as well as stress urinary incontinence. So this is somebody who's taken an additional year of training after completing a 5-year residency to dedicate their career to using devices to help manage more advanced cases or more difficult cases of erectile dysfunction and again, incontinence. There's a lot of buzz about different therapies coming out, shock waves, plasmas, stem cells. Unfortunately, those are not really ready for prime time. Both the American Urological Association and the Sexual Medicine Society of North America really would urge most practitioners to do those under the guise of an IRB or an institutional review board, which would be for a clinical study. There really isn't adequate evidence for us to recommend any of those therapies. And what's listed on the slide, minus one thing I'll talk about, are really the approved therapies for erectile dysfunction as of 2024, again, from the American Urological Association guidelines on erectile dysfunction. One of the major changes between the original form of the guidelines and the 2018, which is the most recent version, currently being revised, however, is that there's a departure from having therapy be the least invasive to the most invasive, or being everyone gets pills, then a vacuum, then injections, and then a surgery. The framework for the guideline was actually trying to be more patient centered. And instead of saying you must do X, Y, or Z, it's to discuss all the risks and all the benefits of all these different therapies before having the patient choose what they want to do. Now, it may seem like a no-brainer to try a pill before sticking a needle into your penis, but there are definitely some nuances to these things. I'll go over all these treatments in a little bit more detail, but I do think that there's more buy-in with some of these than others, and they can affect your sex life beyond just simply being able to get and maintain an erection satisfactory for intercourse. The first treatment goes back to one of the first things I said, which is the most important thing. If there are things you can change in your life, please do that. If you can lose weight, if you can improve your diet, if you can start going to the gym more. Can I tell you these are going to move the needle significantly? It would depend on where you started and where you have to go. But at the end of the day, you're going to be healthier. You're going to live longer. And it can aid in the efficacy of all the other treatment options that I'll discuss. So independently, I would recommend this to absolutely everyone. Psychotherapy or sex therapy can be a useful adjunct to treatment. Again, we talked about depression being a comorbid or related condition with erectile dysfunction. And this is where the provider or the physician and patient relationship is so important. If we do different tests, we do different screenings, and we realize that this is a big component likely to benefit you, then this is great. A lot of times this works best when coupled with some of the other different therapies, but can also work well alone in the correct patient. Pills, these are your sildenafils or Viagras, tadalafils, Cialis, vardenafil, Levitra, etc. These are all the oral medications that you've probably seen. Again, a lot of direct-to-consumer marketing, a lot of telehealth being offered, and these medications work very well as therapy for a lot of men. They do have their side effects: headache, thigh ache, backache, upset stomach, facial flushing, palpitations. There's some reasons not to take them. If you have some advanced eye disease, I would certainly talk to your ophthalmologist or your urologist about that. if you're on nitrates for chest pain or on certain blood pressure medications. It's not something that, there's zero interactions for, but they have a relatively safe safety profile compared to other medications. They work by perpetuating the signal. And I talked about this briefly earlier. You need to have a sufficient signal to have an erection to allow these to prevent the enzymatic breakdown or the breakdown of that signal. So people who don't have that signal, again, men with diabetes, men with prostate surgery that have injured the nerves, aren't going to get as much of a benefit from these medications. And again, that's why the blue part of this bottom of the side says that men with diabetes are less likely to respond. And that's why, because diabetes not only affects the arteries, which are part of the process, but it also affects the nerves. And this is, again, where some of those signals can be affected from this. Vacuum erection devices, these basically pull blood in the opposite way, meaning instead of having your arteries work, this actually allows the veins to pull blood in by decreasing the pressure surrounding the penis. After the vacuum is achieved and an erection is achieved, you can see there's a small band left on the penis below. One of the biggest issues with this, I would say, is it doesn't work for all men, and there's a little bit longer of a learning curve than any of the other therapies that we'll discuss tonight. The penis is usually cool to the touch. As you can imagine, it can affect ejaculation because there's a band right around there. It can affect sensation because it can put pressure on the nerves as well, which are on the top part of your penis. If people are on blood thinners, I really shy away from recommending these. It's actually considered an absolute contraindication. I mean, we shouldn't do it just because it can cause large uh, bruises. But again, it's a little bit less of an invasive way than it doesn't require medication or current cost and can be an option for some men. I'll talk about this in tandem with the injections in a second. But really, again, this and the injections require you to have devices on hand, medications on hand, and there's a lot of buy-in. And again, I think there's, not to use a false dichotomy, but I have lots of types of patients. But for couples that say Thursday at 7 p.m. or every second Sunday, that's our time, and that's where I'm going to be intimate with my partner. Devices like this and the injections, which I'll talk about, can be great. They're added to foreplay routines, and they make it a part of their sexual relations. For people that travel, for people where spontaneity is something that's of the utmost importance, these can be a little bit more difficult. And again, I think there needs to be a good conversation between both parties, the patient and their partner, about whether or not a treatment like this would make sense for their relationship. I apologize to take one step back about the oral medications again, because I think this degree of spontaneity is important. There are several types of oral medications, one of which is used on a daily basis, which is one that I often prefer just because, again, it allows patients to have more spontaneous interactions. And there's some that are used on demand right before the act, which, again, similar to the vacuum and the injection, are things that, need to be planned and have some forethought with. So I've talked about them a bunch without talking about them. These are the injections. They go into the side of the penis, ideally somewhere between 2 and 4 or 8 and 10 o'clock. Unlike the oral medication, this is a different medication. This is the go signal. It is replacing that other signal and it is telling your penis to get an erection, which is why it works in a lot of cases, up to 70 to 80% of cases where the oral medications have failed because it bypasses some of nature's mechanisms to get an erection. That can have unintended consequences. You can have discomfort with the medication. About 1 in 10 guys get some degree of discomfort. And I'm not talking about the needle. Again, one of my mentors always said needle and penis are two words that do not ever belong in the same sentence. And while I think that's true for most of us, the needle's caliber is very thin, and most of the discomfort is actually from the medication itself. One of the primary components of the medication is actually similar to a type of compound that our non-steroidal anti-inflammatory drugs block. And that can cause a dull ache, like a throbbing ache that can last for several hours. That is one of the main reasons some people discontinue is they're sensitive to this medication. The medication can also accidentally be overdosed. An overdose of things like sildenafil can lead to a wicked headache or backache or maybe feeling like your heart's racing. But an overdose of this medication, while you think some is good, more may not be better. It can lead to an erection that lasts for more than 4 hours, becomes painful. And I didn't talk about with the vacuums, but you need to take that band off. And the reason for that is if the penis gets no new blood flow, the tissues start dying, and there can be permanent consequences of that. Usually, if somebody's not that have an erection for more than 4 hours, they need to come into the emergency room to either get the antidote for the injection or even have some of the blood drained out of their penis. The data is somewhat antiquated and they don't have it here, but realistically, about 70% of people remain on therapy at 1 year. I talked about discomfort being a reason for discontinuance. Obviously, the drug not being effective is another reason people discontinue using this. And the third thing was something I alluded to previously is really the lack of spontaneity. And I think as urologists, sometimes we do a poor job of taking a sexual history or talking to the partner because some people start shying away from this, and injections are very specific to this. Unlike with a pill or unlike with a natural erection, as soon as the male partner injects himself with a medication, they're very likely, if they respond, are going to get an erection in 5 to 10 minutes. We know that things change. Maybe the mood is no longer there, but this puts an unfair situation with the patient and his partner, and then now there's some expectation that something's going to happen, and that can cause a lot of relationship anxiety. So typically, when I will have somebody start injections, I bring them back several weeks to months later to check up on the patient and their partner. I like doing couples consultations because I think it's important. Because one person may think this is a great option, the other person may not. That leaves us with the last option that I haven't talked about, which is the penile implant. Now, if anybody's ever seen me in clinic, I often say my two favorite treatments for erectile dysfunction are typically the daily form of tadalafil, which is, again, the medication you take every day and try to get an erection wherever you want because it restores you as close to where you were before any of these diseases that you were, and the penile implant for the same reason that I think it affords couples more spontaneity and having a more reliable result. On the flip side of that, there's a large buy-in. This is a surgical procedure. This is not something that you simply can try and then move on to the next thing. I'll talk about some of the potential, risks of this procedure a little bit later, but there's a large buy-in for that. But that spontaneity, I think, is something important, and it's really, again, a patient and partner discussion with me at the initial consult of whether or not this seems like a good option. The nice thing, as I said, is unlike some of the other medications or the injections, is that this replaces your natural erection tissue with a device. And as long as the device is working and they have pretty darn good shelf lives, you don't get a partial response. It's not like it inflates partially this time. If either the device works and you can inflate it all the way and have a rigid erection that lasts as long as you want, or the device is broken, warranty replacement again, which is a pretty darn rare thing to happen. It is completely housed within the patient. There are no parts you need to bring anywhere from anywhere else. And when you're done using it or done with the erection, you can put it away. The only part of the sexual response cycle that this takes up is the erection. So this does not affect your ejaculation if you're able to do it. It doesn't affect your arousal. It doesn't affect your sensation. It doesn't affect your ability to orgasm. It doesn't necessarily affect your partner's ability to orgasm or have pleasure either. It only affects the erection. Now, some people say it's an upside. Some people say it's a downside. One thing is that when you're done, you have to manually deflate the device. There's no automatic, I've come to, climax and then my erection goes away. You have to manually deflate the device because, again, the only thing this device takes place of is that erectile portion of the sexual response cycle. Most common side effects and complications, well, I wouldn't consider pain a complication necessarily. I think it's an inevitability. It's a surgical procedure on a sensitive area. Most men have pain from the surgery and then have some lingering discomfort, which can last several weeks afterwards. And then they'll have some discomfort the first several times they use the device. I would equate this to a joint replacement. If you have a knee replaced, the surgery is going to hurt. Learning how to walk on it is going to hurt. There's going to be this, several week period of adjusting to it, but then it should become a normal part of your body. Long-term discomfort from either having the device or using it is very rare. Infection definitely is a big complication. Infection is a big complication because this is a foreign body. If it's infected, it must be removed. And if you want to have an erection after a removal of this device, you need to have another one reimplanted. And that's really one of the crux of this is that you can't try it. And if you don't like it, do something else. So it's something important to kind of either understand all the options before making this decision or have failed all the other options before making this decision because you cannot go back from this device. Mechanical function or failure, again, the vast majority of these devices are still working a decade later with proper use. And if it does break for some reason, it can be completely replaced. Erosion is the migration of this through the human body. There are some factors that could put you at higher risk for this: smoking, uncontrolled diabetes, pelvic radiation. But even the erosion rates, I would put it pretty darn rare. I think the last point down here is important. It talks about the people that have them, obviously recommend them to their friends. The only thing I'll say about satisfaction data with this or anything else is you got to remember the patients that are entering this data. And I think something that I take pride in, and I think a lot of other urologists do, is having appropriate patient counseling, meaning not creating some degree of false expectations. So these satisfaction rates really are likely this high because the people that should be getting these procedures are the ones getting these procedures. There's several different implants on the market. We have the AMS 700, which harkens back to the previous parent company of the implant itself. We have the AMS 700 with this new pump that allows for easier use of the device, very similar on all of the components, but is specifically a new pump design, which makes it much easier for the patient to actually activate and deactivate and find in their scrotum. And we have the Tectra, which I haven't talked about, the malleable prosthetics. It's a less complicated procedure, but unlike the other device that inflates and deflates and has a rigid and flaccid state that more naturally mirrors our anatomy and physiology, the malleable prosthetic is just having a rigid erection all the time. I often tell people it's like a gooseneck lamp. When you want to use it, you bend it down into the position. And when you're done using it or don't want to use it, you can bend it down your leg or you can bend it up onto your abdomen. But the penis is always the same length, always the same girth, always the same rigidity. Um, this is the Boston Scientific's AMS 700 implant. There are a lot of nuances to this device that are probably beyond the scope of today's discussion, but a lot of thought has been going on to engineer these devices. These devices started in the late 70s, and there have been many improvements on these since then. The angulation of the pump, the thickness of the tubing, the reservoir itself in terms of its shape to minimize the profile so you can't feel or see any indentations on the outside of the body. The actual coating of the device itself and this proprietary inhibizone, which actually has impregnated antibiotics on it. Some antibiotics rifampin and minocycline that you may never have heard of. And that's a good thing. That means that a lot of organisms are probably still sensitive to them because they're not being used in everyday practice. Obviously, those were chosen specifically based on infection data in older studies, but they work pretty darn well. Again, unlike that rigid device, the malleable I discussed, this really tries to mimic a natural erection. When you want to have an erection, you press that pump several times to inflate the device, and when you're done, you can see the button on top. You press to deflate the device. Again, the quote has been used for 50 years. Obviously, this new Tenaccio pump is circa last year or this year. Some of the other devices, the modernization of this device were made around the early 20 teens, but the current model has really stood the test of time. Hopefully this video will work, but this will give you a little bit more of a demonstration of exactly how the implant works as I just described. And please, this is not meant to be a guide. If you need help with this, please let me know. There are lots of good ways to train, and some of Boston Scientific reps also help with this. As you can see, you press this pump several times, and unfortunately, this is not the new pump in this video, but you can see fluid coming down from that little reservoir up top, and there's a magnification of that reservoir to the bottom right of the screen. That inflates the two cylinders. After you're done, there's that button you press on top, and that will automatically facilitate fluid draining back from the cylinders to that little flat reservoir that's hidden right in front of the bladder. Again, I want to reiterate, all components of this device are completely hidden within the human body. We're about to see an actual patient demonstration of this. So again, if there will be a penis being demonstrated in a scrotum. So please, by all means, avert your attention if you do not want to see this. It's a very long intro slide. I really want you to focus on the actual how easy it is to inflate and deflate the device, and that you're not really able to see the vast majority, of imprints of the device outside the human body. The pump you can see in the scrotum, and that's by design. We want to make things easy for you to use, but the rest of the device is completely and utterly hidden. You can see he grabs the pump right there. He's trapping it with his left hand and he's using his right hand to squeeze the actual pump. And you can see that he now has, you can see that pump kind of under his right hand, or in his right hand rather. And you can see that he now has a rigid erection. You can also see that small scar above his penis is clearly placed using a minimally invasive infrapubic technique. And again, that was designed to show you how minimal of a footprint that this device really has on the external of the body. You can see the button he's pressing, it's on the back of his scrotum. His left index finger is now pressing that button. And you can see without anything, the device is just deflating. That reservoir that you cannot see at all is being filled up with the fluid and his penis is deflating back to a flaccid state. Gently going to help facilitate some passage of the fluid out. And just like that, he's flaccid. So, what to expect if this is something for you? The first thing to expect is to have at least a 30-minute conversation with a prosthetic urologist to go over the risks and benefits in great detail. Again, somewhat beyond the scope of tonight's talk. But the procedure is often a 45-minute to an hour-long procedure. It's either done on an outpatient or a 23-hour observation, meaning you spend one night in the hospital and go home early the next day. My technique, I do use the minimally invasive infrapubic technique on new patients. For people that have previous implants, I will revise it through a separate incision on the scrotum to prevent any injury of the nerves of the penis. It is typically performed under a general anesthetic. In terms of activity afterwards, depends on what you do for work. Usually like people to take a few days off, at least 72 hours off of what they're doing. And then if you don't lift more than 10 to 15 pounds, can return to light duty several days after the procedure itself. I actually leave a drain in after the procedure, sometimes for one, sometimes for up to 3 days, depending on the output. But there's a reason I do that, and that's because while it says here the urologist usually activates somewhere between this 4 to 6 week range, usually I'm activating people closer to 2.5 to 3 weeks. So they have early activation of the device, which has been shown to have earlier return to sex, more people using the device, and less complications with how the tissue that your body builds around the device, how it builds it, so that there's less discomfort with use, as well as less problems with the device acting in different ways. Cost and coverage, I make no claims about how things are reimbursed in this country, whether it's through Medicare, Medicaid, or private insurances. I will tell you that a lot of Medicare covers this. Medicaid, I have not had much success with, and a lot of private insurances do. That being said, before you would have any kind of procedure, obviously everything would be run and you'd be given the numbers before undergoing the procedure, not be left with a huge hospital bill. This is just some anecdotes. Again, I highly encourage you all to go to that QR code with the hard series as well. There's a lot of the information I just discovered. I think it's great for somebody such as myself who does a lot of these to tell you about them. I think it's even better for you to learn from real patients having the experience because it will give you an exact picture of what to expect. But you can see this person's quote. And if you remember what I said earlier, erectile dysfunction is more than just a problem with erections. It becomes a self-esteem issue. It becomes a relationship issue. That's just a quick snippet from the Heart series. Um, I'm not going to go through all this. I think this really re-encapsulates what I said. It's got a high satisfaction rate because I think we do an excellent job of selecting this. I think the implant is a great product. I think it's simultaneously oversold to some people as a cure for their problems, which it's not. But I think it unfortunately is also undersold to a lot of people as being some kind of a dangerous surgery that has a high, high risks associated with it. I put it somewhere in between those. And again, it's something that I think is worthwhile discussing and determining whether it's right for you and yours. It has a high satisfaction rate. Most insurances do cover it. The market life or the shelf life of these devices does usually extend beyond a decade. And the nice thing about this, as I mentioned, is that this natural and or this spontaneous types of erections, which some of our more advanced treatments don't necessarily offer. What are the risks? I will tell you that 97% of these go off without a problem. There are complications. There are risks. One of the big risks that I said is that if you have one, you remove it for some reason. And again, you saw the satisfaction rates, and those numbers are not fabricated. They're very high. But for those people who do not like it, if you have it removed, you cannot go back to pills, injections, vacuums, etc. The tissue is distorted in a way that would not allow any of those to work. There are risks of infection, I mentioned. There's small risks with bleeding. There's risks with injuring structures around the device itself. There's device malfunctions, migration or erosion, and then soreness, which again is pretty darn rarely chronic as long as the device is properly sized. Again, you're not alone. This is an incredibly common disease. I told you that over 50% of people over the age of 40 struggle with it at some point in their life. So please, by all means, it's great to learn more about this, but it's also great to connect with other people in your situation to be able to kind of bounce ideas off of each other. It's great to also see people that have been through these different journeys and kind of their progression to what ultimate treatment option that they decided to land on. This is a bunch of obligatory slides I need to put up here about the penile prosthetic itself, about both the inflatable as well as the malleable implant. All right, I apologize. It took a little bit longer than I meant for it to. We will quickly switch gears to stress urinary incontinence management. Um, Stress urinary incontinence, somewhat like erectile dysfunction, is a mechanical issue. There are things we can do to reduce incontinence, namely, you drink less fluids, you will leak less. If you empty your bladder out more frequently, you will likely leak less. There are some mechanical fixes really designed at strengthening that sphincter muscle, which I showed you that picture. Is one of our continence mechanisms, including pelvic floor physical therapy, doing independent Kegel exercises, and biofeedback, which is a technique that a lot of the physical therapists will use to teach you about your pelvic floor and how to contract your muscles when you think you're about to leak. There are ways that we can manage the incontinence: pads, diapers, catheters, usually catheters that go over the penis to collect the urine, clamps that clamp onto the penis to prevent the leakage of urine. But these don't necessarily fix the problem. They just allow us to kind of manage it. The Advanced XP male sling system is a potential surgical option that is designed at restoring the real course of the urethra and allowing our natural sphincter complex or our muscles to do what they were doing before prostate surgery. It's good for mild to moderate incontinence, and it doesn't require any mechanical, pressing buttons or do anything to work. And it has been shown to reduce the number of pads that people use on a daily basis in quite a high number of patients. There's some data regarding its use for or against radiation. Again, these are usually people leaking lower amounts of urine that have not been irradiated and are in pretty good health. It acts as a hammock. And again, you can see this little sling area between these muscles pulling that urethra back up and restoring its natural position. And that's really how it's designed to work. The other surgical option for stress urinary incontinence is the artificial urinary sphincter. Again, from its original parent company, the AMS 800, is truly considered the gold standard in stress urinary incontinence management. Instead of relying completely on your sphincter to help control the actual flow of urine, kind of like the penile prosthetic, you are entrusting a mechanical device to mimic the function of that. The most important things here are that you're able to operate that, and it says usage of good cognitive ability and manual dexterity. That means for people with memory issues or can't really use their hands reliably, this may not be the best option. There are three parts of this. There's a balloon, the pressure regulating balloon, that again, similar to the penile prosthetic reservoir, sits somewhere in front of your bladder, under some of your abdominal muscles. There's a cuff that goes around the urethra. That cuff is the new sphincter that mimics the natural tightening of your sphincter. And there's a control switch that's also placed in your scrotum. You press the control pump, and what happens is the fluid that is already pre-filled around the cuff or in the sphincter disappears, and it slowly drains into the pressure regulating balloon. As the pressure regulating balloon reaches its terminal pressure, it then automatically starts pushing the fluid back into the sphincter over the course of a minute. So it naturally allows you to have a stream and slowly shuts it off. Let's see a video. So this model, they're going to press that button right there once. They should not be pumping it multiple times. They should be pressing it once. And that will allow the fluid to drain out from that sphincter cuff, as you can see in the top left hand of the screen. And now it is refilling. I'm going to play that again because that was so short and I did not like that. Let's do that one more time. Perfect. So they're going to press that once. The fluid that is in that sphincter is going to be jettisoned back into that uh, clearish, whitish part, the reservoir. So you can see the fluid leaving the sphincter. Urine is now coming out. And then after that pressure regulating balloon reaches max pressure, the water is then, or sterile saline is then returned and closes that cuff down, trying again to best mimic your natural physiology. Both of these procedures are outpatient procedures. The sphincter does require two incisions. One is for that little balloon component. The other one is for the actual sphincter itself, where it's this thing only requires the one incision, which is the same size incision for the sphincter, and two poke holes for the actual device to be seated correctly. So again, both of them are fairly minimally invasive outpatient procedures. Unlike the penile prosthetic, I do wait a full 4 to 6 weeks to activate this. And there's a reason why. If for some reason you went 4 to 6 weeks without having an erection, it would not be the end of the world, I hope. But if I activated you and you were unable to urinate, that creates an emergent situation. And a lot of that has to do with healing, swelling in the scrotum, etc. afterwards. The last thing I would want is for somebody to go into urinary retention, go to an ER and have a misadventure or a complication. So there's a reason why it is really important to wait several weeks to allow people to heal from this. Again, very high satisfaction rates. Patients would recommend it to friends or family. Longevity rates aren't quite as good as the penile prosthetics. You can see these are pretty good up into 6 years. You know, more than half the devices are typically working by 8. These are devices that may need to get replaced, but again, they're a little bit less of a morbid procedure than, say, the penile implant. And we do these devices on men, you know, and replacements in their 80s and beyond because urinary control is such an important part of daily life. Again, it's unlikely you're getting an erection 4, 5, 6 times a day with a penile prosthetic, but having a functioning sphincter is super important because it's likely you are urinating that many times a day. And for some people, they're going through that many diapers. Again, I've had almost no troubles with coverage for this. I don't want to jinx anything. However, it's something that the institution would work out with you well before you would make it to the operating suite. Yeah, I mean, this is I think the best case scenario here is somebody who is either 9 pads a day, multiple diapers a day, won't leave the house, can't go see their friends, cannot even go to the movies, and now has 0 to 1 safety pad a day. It's a completely life-changing operation. Um, yeah, I mean, I don't know what else to say about this. You know, for those of you who are not struggling with urinary control, this is definitely one of those pathologies that we have some really life-altering procedures for. Risks. Obviously, nothing comes without risks. Again, similar to the penile prosthetic, it's a fairly low risk procedure, but does have things: bleeding, infection, device failure, device erosion. Again, going into the wrong place, going into the urethra. Need to explant it, need to reimplant it. Um, Unlike the penile prosthetic, typically when a device is removed, the patient is no worse than where they started. Um, Whereas somebody with a penile implant removed will not be able to get an erection until a new one is put back in. So, as a summary, there are options for stress urinary incontinence. Unlike erectile dysfunction, there is a definitive first line therapy. Anybody who has their prostate removed, if they see me before 1 year, I will send you for pelvic floor physical therapy and biofeedback to make sure we get the most out of your pelvic floor muscles. And if that is not enough, then obviously we would discuss all the surgical options and what would work best for you and your lifestyle based on your cognitive status, your dexterity, and your desires. And this is the obligatory slide about the safety of the Advance XP, as well as the artificial urinary sphincter. I just want to take a really brief aside before I close this to tell you that Boston Scientific has done a great job of having these patient champions on their website. Again, these are men that have undergone these procedures that want to tell you about their experience. And it's not something where it's the most glorified thing. It's not saying, I went in, I got my sphincter. The next day, I was completely continent. It was the best thing ever. It's their real stories. It's about the healing process, the fact that they had this discomfort, that they needed to learn how to use it. So again, if you want to hear from talk to a real person about their experience, I would highly encourage all of you to check this out. And this is both for the sphincter as well as, and the sling, as well as for the penile prosthetic. And these are a bunch of references for the presentation itself. All right. I wanted to thank Boston Scientific again for putting this together. And I will take any questions at this time.